Hello, my name is Nicholas Herrman. I'm an emergency medicine resident, and I appreciate you taking the time to listen to my presentation, which is entitled Impact of a Femoral Nerve Block Guideline for Hip Fractures in a Community Emergency Department. I have no disclosures for this talk. A little bit of background. Hip fractures are very common, particularly in older and female populations, and hip fractures are very, very painful. Traditionally, we've relied a lot on opioid pain medications for hip fractures, but as I'm sure we're all more and more aware, opioids have a lot of risks, especially in the older populations that typically suffer from hip fractures. So more and more we're moving towards alternative pain control strategies, and in particular there has been a lot of work looking at regional analgesia with femoral nerve blocks. And previous studies have shown femoral nerve blocks to have quite a bit of benefit, particularly with pain control, but also possibly with preventing complications such as delirium that often accompany hip fractures. However, most of the work that has been done with femoral nerve blocks has been performed at large tertiary academic institutions, and data from community centers is significantly more lacking in comparison. This work was performed in a large community emergency department, and some time ago, this department instituted a femoral nerve block guideline for patients presenting with hip fracture. And in particular, patients above the age of 60 who were diagnosed with new hip fracture in the emergency department were eligible for femoral nerve block, particularly if they met a couple inclusion and exclusion criteria. Specifically, the affected limb had to be neurovascularly intact, there couldn't be extensive lower extremity trauma outside of the hip fracture, and the patient could not be supratherapeutically anticoagulated, though therapeutic anticoagulation was acceptable. So our objectives were first to see, does this femoral nerve block guideline for hip fractures increase the performance of femoral nerve blocks in eligible patients? But also we are trying to examine, do these femoral nerve blocks affect opioid use in patients admitted with hip fracture? And also, do the femoral nerve blocks affect other patient measures, such as hospitalization complications like pneumonia, urinary tract infection, and delirium, as well as hospital length of stay and time to operative intervention. So we designed a before-after retrospective chart review. We had full IRB approval, and specifically we looked at 1 year's worth of patients who were admitted with hip fracture prior to guideline implementation for the femoral nerve block guideline, and 1 year's worth of patients after guideline implementation. We did exclude a 2-month washout period immediately following guideline implementation. Patients had to meet the inclusion and exclusion criteria for the femoral nerve block guideline that we implemented, and also we only examined patients who underwent operative repair within 24 hours, with the thought being that a single shot femoral nerve block is very time limited, and if the patient did not go to the OR within 24 hours, it was unlikely to have prolonged effect past that point. Here are our results from the rate of performance for femoral nerve blocks for eligible patients. You can see in the two time periods we had a total of 308 patients, and in the time period before guideline implementation, only 5 of the 126 patients underwent femoral nerve block. However, in the time period after guideline implementation, 104 out of 182 patients underwent femoral nerve block, with a statistically significant p-value of less than 0.001. In terms of the other outcomes we measured, here's a table summarizing their results. We found that in the patients who did not undergo femoral nerve block compared to the patients who did, there was no statistically significant difference in total morphine equivalents used prior to their repair in the OR. In addition, hospital length of stay, time to operative intervention, as well as rates of hospitalization complications such as delirium, pneumonia, urinary tract infection, and in-hospital mortality were also not statistically significant. So in conclusion, we found that implementation of a femoral nerve block guideline for patients admitted with hip fracture in this community emergency department increased femoral nerve block performance significantly. And based on prior literature, this is probably a good thing, as previous work has shown that femoral nerve blocks can decrease opioid use and increase patient outcomes with decreased complications such as delirium. However, in this particular study, we did not find any difference in opioid use, nor did we find any difference in hospital length of stay, time to operative intervention, or the complications that we previously discussed. So certainly this study has a number of limitations. We had 308 patients, which for our institution was a pretty reasonable sample size, but there are still limitations with a relatively small sample size. In addition, we only examined patients who went to the OR within 24 hours, and we also only examined opioid use prior to the patients going to the OR. If we expanded that, possibly we would have found a difference in opioid use. Furthermore, especially with the hospitalization complications and other variables we looked at, we didn't have any pain scores or other subjective patient-centered outcomes, as these were significantly more difficult to abstract from the chart in this retrospective chart review. In terms of future directions, our goals would be to hopefully increase the sample size to help see more subtle differences, as well as to consider other outcome measures, especially more subjective patient-centered outcomes such as pain scores. With that, I thank you for your attention, and I thank you for listening to this talk. Have a good day.